So yeah, Krista, Ben, everybody who's in attendance, thank you for the invitation. I really want this to be as meaningful to you as possible. So, I'm going to talk a little bit about my experiences with COVID-19 because I think that blends a lot of what being an epidemiologist and a public health professional is like in unusual times. And so I've got some PowerPoint slides just to kind of walk through that. But, and Krista already sent me a few of the questions that people have asked. But I want this to be, again, whatever you want. If you want to know anything about being an epidemiologist, being in public health, working with the media, whatever it is, I encourage you at the end of this to just be vocal and ask as many questions as you want. I'll stay as long as need be because, again, I know how it can be a little bit of a black box sometimes as to what being a public health professional is like. So with that said, I'll do a little bit of an introduction because one of the questions that I received already said, what steps did you take through academics and career moves to become an epidemiologist? So I think context matters. So I'll answer part of that question now and maybe part at the end of my talk. So I thought I wanted to be a physician, a real doctor, as they say, not a PhD. And so I was the first person in my family to go to college. And so as soon as I declared a pre-med major, everybody was just on the bandwagon, where I worked. Everybody was just so happy. Oh my God, he's going to be a doctor. And to me, I was pretty good at science. I took the MCAT. I only applied to one school. So I got accepted to medical school, and it all just kind of, I don't know, you kind of go through the motions sometimes towards a goal without ever thinking about why am I doing this? So it wasn't until I actually got accepted to medical school and started medical school for a couple of weeks that I took a step back and said, is this really what I want? Is this how I want to impact people's health? And for me, the answer to that question was no. I don't want to interact with people once they get ill. I believe more in affecting populations, preventing them from getting ill. I just hadn't done my homework ahead of time. And so as you can imagine, people thought I was absolutely insane. A lot of people take a pit stop in public health while they're trying to get into medical school. I was the anomaly. I took a step back and said, you know what, I want to leave medical school. And now I know I want to get a master's degree and a PhD in public health. And so, hardest decision I ever made in my life. Went through a lot of ups and downs in terms of, am I a failure for not going through and being a physician? For me, it was the best decision I could have made. I'm very happy with what I do. I'm very happy with the way that I affect people's lives now, and never more so than during COVID-19. So I graduated with my PhD in 2014. My first job was in Houston at Baylor College of Medicine. I was there for 5 years. I was promoted from assistant to associate professor. And then, I was born in Tampa, raised in Tampa. My whole family, all my friends are in Tampa. So it was a nice move back. It just happened to be at the end of February when I came back to USF. And so that was right before the stay-at-home orders. So it's been an interesting return back home. Kind of being so excited about the entire process and then having to kind of sequester myself and do this work from home kind of thing. So that's just a little bit about me. I'm going to try and share my screen and hopefully I'll be successful with this. And again, my goal is, I think this is the right one. My goal is to just kind of walk through a PowerPoint presentation. I encourage you, if you have questions in the middle, I don't mind being, interrupted in a sense. But I thought this will give some context as to what one person's experience with COVID-19 is. And it really is the unexpected COVID-19 rabbit hole that I'm going to talk about. So again, a lot of this I view as answering a public health call to service when you're an expert in a domain, when there's a lot of uncertainty in the public and just wanting to have an appreciable impact on people's lives. This is kind of my journey in the past couple of months. And so the goals of my talk, again, it's to share my own story. It's the 0 to 60 miles an hour in terms of the post-COVID new normal. I think it's largely reflective of what everybody's gone through: students, staff, faculty, workers, like everybody. There's nobody who's not been impacted and had to be very adaptable to this kind of new normal, at least for a while. I am going to introduce you to what I think is a useful resource. One of the things I'm very good with is data and presenting data and helping people to understand data. So the dashboard that I've developed specific to Florida is a good supplement to what the state provides. I think it goes a lot in more detail. And so I'll show you a glimpse of what that dashboard looks like. And last but not least, I'm going to try and motivate you, when you get in your professions, when you become a public health professional, no matter what the discipline, whether it's epidemiology or anything else. If you end up becoming a physician, I think it's important for us to answer the call when the public needs us, because I'm going to talk to you about a lot of time and effort that I put into something that is largely unfunded. This is above and beyond my job. I don't have a grant to do this work. So this is just something that I kind of do on my own time. But I think it's immensely important when people are struggling to find reliable information. And so here's my silly little journey of where I'm going to take you in the next, 20 to 25 minutes. I want to start by saying I'm a maternal and child health epidemiologist. So I was the former president of the National Birth Defects Prevention Network. That's the largest nonprofit organization for birth defects surveillance in the United States. And I was president shortly after the time that we went through Zika. So Zika is another virus that didn't quite get as much attention as coronavirus has, but certainly at the time it was immensely scary for us in the maternal and child health world, because although it was no big deal for just about everybody except for pregnant women, it was a really big deal for pregnant women. If they contracted the Zika virus, there was a much higher likelihood that their child would come out with, different defects of the central nervous system, including microcephaly and having developmental delays. And so I was kind of already used to trying to respond in a public health way to a virus, but of course, COVID-19 has been something even more striking. So my big thing at the beginning, why I got involved in COVID-19 outside of just being a concerned citizen, is although I knew the risk to younger people, whether it's young adults or children, it seemed to be way smaller than elderly, and that certainly continued to be the case. I knew that if a lot of children, there are 74 million in the United States, if enough of them were infected, we could still end up with large numbers of children who require hospitalization, intensive care, and who ultimately die. So this is where I began. And so again, early on in the pandemic, we were exploring a lot of data that was coming out of China because we didn't have enough cases in the United States, certainly not enough for research to emerge on it. And so we paid a lot of attention to the kind of clinical interpretation or the clinical classification of cases in children. And again, that's what was most important to me. It wasn't that I didn't think what was happening in elderly populations wasn't important. It certainly was, but there were already a lot of eyes on that. And so again, remember, I didn't get into this to try and help the public per se. I got into it because this is my area of expertise in my line of research. So I focused on the kiddos. And again, something that you should always pay attention to is risk versus burden. So again, I kind of alluded to this. A small proportion of kids infected with the novel coronavirus develop severe cases, right? And again, this is early on coming out of China, and that's maintained, although we've learned a lot about some of the subsequent complications of COVID-19, the fact that it can be more of a chronic condition, that we don't know exactly what could happen to children, even if they're asymptomatic or mildly symptomatic, could it cause longer term problems? But I think, the universal answer to, are they less likely to develop severe disease? The answer is universally less. But we knew that community spread, again, and this was early on, if we didn't engage in appropriate mitigation strategies like mask wearing and social distancing, if we got enough community spread of the virus, it could reach a very large proportion of the entire population, kids included. And so again, 74 million children in the United States. So again, even if that risk is low, an individual's risk is low, if enough children are infected with the virus, we could end up with high numbers. And I'm not, because a lot of the initial talk was on flattening the curve. I'm not talking about flattening the curve. I'm talking about just a lot of kids experiencing severe illness, even though the risk is small. And so that's why I got involved in this. We published a paper. This is just one of the figures from the paper that we ended up publishing, and I'll just draw your attention. So I'm not very big into the predictive modeling. There are people who like to do that and predict what's going to happen in the future. We weren't really about that. We were like, what do we know now? And at the time we said, since we can't accurately predict the future, let's give you several scenarios. And so, those scenarios involved what proportion of the population might actually get infected with the virus. And again, this was early on when we didn't know how well mitigation was going to work. And so what that blue arrow is pointing down to is we said, if 5% of the population ends up contracting the virus, including children, we estimated, based on the data that were coming out of China, that we'd have over 1,000 children in the United States, not that would be hospitalized, but that would end up in a PICU, a pediatric intensive care unit. So these are critically ill children. And so what I'll draw your attention to, let me see if I can move this out of the way, because I don't know if you can see that, but it's blocking my view. Okay, so one of the things that I'll talk about is a project that we're actually tracking, severe illness in children throughout the United States. But as of this is September 7th, so this is already more than a week old, we already had over 1,301 pediatric intensive care unit admissions in the United States. And we know that it's an undercount because in the registry that we have, we know that only about 80% of pediatric intensive care hospitals are actually submitting data to this. So, again, I know the United States is very large, and I know that I hear a lot of things, well, kids are impacted by other outcomes. When I see something that's probably closer to 1,800 children who are critically ill that require mechanical ventilation, that's something that concerns me. And so again, that's why I got involved in this. This is just the title of the paper, not that important. One of the other big things that we kicked off, again, it's an unfunded project. I had some former colleagues who were epidemiologists and professors and just wanted to put a lot of effort into trying to track severe illness in children throughout the United States. So this is something that we continue to update every couple of days. It's called the Coronavirus in Kids Tracking and Education Project, or the COVE-KID project. And again, we just try and, one of the things is trying to bring some global data across all states to people. The other big thing that we try and do is urge states to improve the consistency of reporting. In order for us to understand racial ethnic disparities, states need to report information on race, ethnicity in the pediatric population. And so again, we found such heterogeneity in the way that states were reporting information on children that we came up with a state report card and we tried to grade them on how they're doing. And it wasn't really to slap them on the hand, it was just to encourage more standardized reporting. And so that effort continues on. And again, based on our estimates, and I won't get into the how we do this because it's a little bit complicated, but we're estimating that slightly over 3 million children have contracted the virus. The overwhelming majority of those were asymptomatic and have not developed any sort of severe outcome. But it just shows you that, nearing 5% of the population is likely infected in terms of children. So that's just kind of why I got involved in this as an epidemiologist. And, again, if you think about yourself being a professional in the field one day and you're doing research and this thing explodes from out of nowhere and you're a public health professional, your tendency is going to be, well, let me get engaged where my area of expertise is. This is now, the rest of this story is how I started to break away from that specific area of expertise and started to do things a little bit out of the box. So the next thing I'll talk about is the utility of data dashboards. This is hopefully, you being public health students, hopefully none of this is going to be foreign to you. This is the official Florida Department of Health dashboard for tracking COVID-19 in the state. This is one of their pages. This is another one that gives a breakdown by race, ethnicity, the age distribution of all cases, and then even a zip code level map. When I came to this, I wanted to ask questions of the data, again, that were meaningful to me. I didn't just want this zip code level map. I didn't want an overall age distribution. I wanted something like an epidemic curve, the number of cases per day, and I wanted it specific to the pediatric population. I also wanted it specific to Hillsborough County or Leon County or Alachua County because I knew that the answer of how are we doing would be different in different areas. And I could not get that granular information from this dashboard. So again, my involvement to a different level emerged from I wanted more information than was made available. So this is an example of, at the time, what I could not determine. Cases, hospitalizations, and deaths, specifically among the pediatric population. The state has started to submit in mid-June, I think it was, a pediatric specific report, but at the time when I was digging into the data, this was not available. I couldn't get any age-specific rates at all. I could just get like cumulative cases by age and the age distribution, but I want to know age-specific rates of death, of outcomes. Like those are all things that as epidemiology students, you certainly, don't just want frequency, you want rates. Give me, the number of cases relative to a population. I wanted to know, how is the age distribution changing over time? I can tell you now, after tracking coronavirus, I think everybody knows this, at the beginning, because testing was not very expansive, who was getting tested? Those people who developed serious symptoms, the elderly primarily, right? So we saw a lot of older people comprising cases early on. And then as we move forward in time, as testing got more expansive, we saw an age distribution shift to younger populations. And certainly as students have returned to college and to K through 12 schools, we've seen a shift even more recently. So we'll talk a little bit about that, but at this time I couldn't get any of that really useful information. Mortality rates per capita. Don't just tell me how many people have died from COVID. Tell me how many people have died relative to population. Temporal trends in my community. So again, I could look at their zip code level map and just say, how many cases are in zip code, whatever. I could pick 2 or 3 zip codes and look, but I couldn't see how has this zip code progressed over time. So anyway, a lot of different questions that I couldn't answer, and that always bothers me. I want to be able to answer questions. And so one of the things that was nice is the Florida Department of Health did make a lot of data sets available. And so this is what I did. I started to download what they call the case line data. This is information on each case, each person who's tested positive with coronavirus in the state. And it had information on what was their age, what was the county of residence, when did they test positive, what was their sex. So a lot, it wasn't a ton of information, but it was more granular information that I thought, well, if I can get my hands on the raw data, I can probably aggregate it in different ways to answer meaningful questions. I downloaded information on deaths. I looked through very, very long. When they first started to release these reports, they were over 1,000 pages long, these PDF documents that were a report. And there was a ton of reports, a ton of different PDF documents that I would download. Hospitalization information from the Agency for Healthcare Administration, the National COVID Tracking Project, correctional facilities, and looking at federal information. So I tried to compile as much information as I could, and I started to put it together in a meaningful way. So I started to kind of build a dashboard for myself. So if I needed to ask a question of, in the 10 to 17 population, what's been happening to the case counts in various counties, I could answer that. The key is, all of this was for me. None of this is yet for the population, but I'm hoping this will also ring true to you as well, that your inner circles can fuel your passions. What do I mean by that, and why do I have misinformation highlighted? Hopefully this is not, again, going to be new to anybody, but I wasn't very interactive on social media, especially Twitter. Twitter, I had a couple of followers, never went on Twitter except to maybe post a random picture of my young child. Facebook a little bit more, because when I moved away to Houston, I would share pictures of my son so that my family could see them because they weren't with me in Houston. And so when I started to go back on Facebook, one of the things that I noticed is a lot of people were receiving a lot of just genuine misinformation. For example, I think most of you have probably seen when this group of doctors got up in white coats in front of the Supreme Court and were speaking very eloquently and passionately and spewing nothing but nonsense. And when I say nonsense, I don't mean like we look at the data and we can have disagreements about what the data say. I mean, it's contrary to what 98%, 99% of all scientists would say when you look at the information in total. So that's what I call misinformation. And so I took it upon myself in my inner circles. This is my family, my close friends who are misinterpreting the data. I thought, let me put some information out there to quell this, to put some more factual information for them. Another one was hydroxychloroquine. Certainly that's gotten a lot of press. Again, at the time when I made this post on August 2nd, the level of misinformation that they were receiving was pretty profound. And again, so I took it upon myself to understand the body of the evidence and try and provide meaningful responses. It wasn't just good enough to say, well, these people are crazy, they're just spreading misinformation, I'm going to ignore it. That when you ignore information like that, it can spread. Nobody challenges it. And so a lot of people start taking it as factual because it looks like it's coming from reputable resources. It's people who dress up in white coats. And so again, a lot of this emerged from my desire to try and battle the misinformation. And so the other thing at the top left here that I started to do is people were just not able to understand the information on the state dashboard. And so, a good example of that is case positivity. You hear a ton about that. And so I put together a little silly video and I tried to explain to people, well, here's what the case positivity means. Here's what you should take home from it. So just, again, trying to help my inner circles understand this. And so I started to use some of the visualizations that I had developed. So this is just your traditional epidemic curve, the number of cases per day in the entire state, and then the 7-day moving average. The red line is the trend line, right? And so I made this available, but then I showed them, well, and this is for Hillsborough County. And this is for the 65 and over population. But this is for the 20 to 34-year-old population. And obviously, if you look at the shape of those two curves, they're saying very different things. In one of the groups, we've seen a profound increase at the end of the curve. In another one, we saw an increase early on and then a little bit of an increase after, right? Different messages. I was drilling down. That's my really stupid graphic at the bottom left. It's a drill. I'm able to drill down to the data because the answer is not the same for different age groups. The answer is not the same for different counties. And so when I shared this with just my social media group, they're like, oh my God, like you have to make this available. You can't get this at the state. And so that's where, again, this was just one of the posts back to me. You really must make this resource available to the public. So I thought, well, you know what? You're right. It currently doesn't exist. So let me develop a resource. And so here is currently, so I've got a website, I'm happy to share it if you haven't already seen it. It is specific to Florida right now. And I think, and this is not patting myself on the back, I think I try and bring a lot of very granular information to people that they can get some of it elsewhere because I want my site to be a one-stop shop for them. But a lot of the ways in which I present information to them, I don't think you can get in many other places right now. And so obviously when you make this decision, what you see on the left there, those are just all of the different data sets that I bring into the fold every single day. This takes me a couple of hours every day to compile all of this information, even though I have a lot of automated procedures, but I try and bring it together, merge it together, and then use Tableau, a software, to make the visualizations kind of come to life for people. But when you start to produce something that now you're making available to the public, you really need to take responsibility for that. And so I've really felt a lot of pressure, even if I'm really, really busy at work or if I've got something going on personally, I still make sure I update that data tool on a daily basis. And, I'm constantly double checking myself for errors because, again, now you're putting your reputation on the line, especially when there's so many well-organized groups on social media that also have these really nice looking sites and they're spreading misinformation. As soon as I start to do things that are inaccurate, it discredits me and it does a disservice to other scientists. So if you choose to venture into these areas, again, it's a lot more pressure, but it's a call to service. It's something that's a valuable resource to people. And so I supplemented this website, and I'll show you a little bit about it. I started to engage on Twitter. That was a recommendation of people saying that's a good way to get information out to a lot of people who are looking for it. And so I started to, post information, get some more followers, and I post quite a bit now on trying to help people understand information. I've got my own little silly YouTube page that, again, just tries to put videos together when I get a request from the community on, I don't understand this. What do they mean by a lag in death reporting? What does that mean? What is the difference between reported hospitalizations and current hospitalizations? What is a 7-day rolling average? What are the case positive? So when you get these questions, I do my best to try and answer them within reason. And so this is just, again, some still shots of my dashboard. If people are actually interested in walking through anything, I'm happy to actually go to the real site, but these are just some still shots. I try and give a snapshot, right? So the good thing is when I took this picture, everything in Florida in general had been trending down in the right direction. Reduced number of cases. Yes, we were doing less testing, but all of the other indicators look good too. Decrease in case positivity rates, decrease in hospitalizations, both reported hospitalizations daily and current people hospitalized, and then in deaths. So everything had been trending down in the right direction, and in many ways kind of continues to do so with rare exceptions that I'll get into. This is your epidemic curve. And again, you can get an epidemic curve anywhere. What my site, I think, helps is if you see on the right-hand side of this, people can pick different age groups that they're interested in. They can, if you wanted to look in the 10 to 14 population, in the college age population, in the 80 plus population, or combinations of different age groups, you can filter and you can make that epidemic curve whatever you want. You can also filter on gender, on county. So again, the big thing that I try and offer is the ability to drill down as deep as you want in the information. This is just, showing you how the age distribution of cases has changed over time. So you see at the top left of this visualization, the reddish colors, those are the higher, vulnerability populations, the 70 years of age and plus. And you can see that they make up about 20%, sometimes a little bit more of all cases early on. And then as we started to expand testing and we started to capture more asymptomatic cases in younger people, you can see the younger age groups in June and July start to make up a much higher proportion. And then more recently, I haven't actually updated, the still shot I took here does not get the last 2 weeks, but my current dashboard has it. We've seen a big increase in the 18 to 22, the college age population more recently as we return back on campus. Just a few other visualizations. This is showing you, a map. I think people can really understand maps, especially, where do I live? What is the case fatality? So of all people who have been defined as a case, who have tested positive, what proportion have died? And then also asking the question, the mortality rate, right, of all the people who have died relative to the entire population, not just cases. So I try and give those two because they answer very different questions. And then again, I think another thing that I think sets my dashboard outside of everybody else that I put a lot of effort into is when you hover over anything, if it's a bar graph, a line graph, when you hover over something, it's going to give you way more detailed information to make sure that you're interpreting the data right. So in this case, if you hover over any county, that's what you see on the right-hand side of this. I had hovered over Miami-Dade and took a screenshot of it. You get the population, the median age of the population, the median age of cases, the median age of people who died. You get information on cases and deaths and hospitalizations. And you even get things that help you to interpret, putting rates in context is hard for people. So like when I say the rate of cases is 59.5 per 1,000 people, what the hell does that mean, right? But if you look at the bottom, there's currently one case in every 17 people. People can understand that. Oh, wow. So every 17 people in the entire county, one in every 17 has the novel coronavirus, has COVID-19. That's a little bit more interpretable. So you have to think about, different ways of presenting information so that people can understand it. This is another nice one. If people are interested in just a few zip codes, this is Pinellas County. And so if I highlighted, 7, 8 different zip codes, and when you highlight it in the map, it shows you how the cases have changed over time. Again, I'm just giving you the impression of trying to bring information to people in a granular format. So if they're concerned about their own communities, they can get nice granular data. And again, I didn't collect any of this data, right? This is information that's already just made available publicly. I just pulled it all together and am presenting it in a way that is useful to people. And then last but not least, this is just a lot of information on, what's really important, which is the more severe outcomes of COVID-19. So this is on hospitalizations, both overall and by day, and then for specific counties and where does Florida rank in, compared to other states in the nation. So again, you can bring a lot of really useful information to people. And then I also focus on, because I am an epidemiologist, methodology, right? So I saw a lot of media outlets at the beginning, they'll say something like, there were 250 people who died today. And when we learn about 250 people who have died, the thing is, because of lags in reporting, that's a false statement, right? 250 people didn't die today. We learned about 250 people who died. When they died could have been yesterday, could have been a week ago, could have been 2 weeks ago. And so what this visualization shows, you can see a lot more red as we move from left to right. That means that the time between when somebody dies and when that is reported to the state has increased substantially over time, which again is problematic. If we're trying to monitor deaths as an indicator of severe disease, we need to be aware that sometimes these deaths are 5 and 6 weeks delayed in their reporting. So again, trying to help not only just lay people, I don't think this is necessarily a layperson visualization. It's more for scientists and people who are maybe interacting with these data at a higher level, helping them to also understand it. And then silly little animated visualizations. This is one that got a lot of attention. Let me see if I can play it. Yeah, so what this is showing is each day as we learn about new deaths, right? When do the deaths occur? So you can see these are reported in June. I won't bore you with the entire visualization. I'll go to the end of it and I'll just show you. So these are deaths, right? In blue. Anything you see here in blue was reported in September. But look at when these people actually died. This is August. This is July. This is the end of June. So you had things that are reported in September, deaths that are reported in September, but they took place in June. So just to give people a sense of the reporting lag. Plus, I just love to play with data. So, doing those kind of animations just soothes my soul, kind of calms me down a little bit. And then, the next stage of all of this, so I develop a resource, I start to make it available to people. It starts to get a lot of attention. The National COVID Tracking Project said, you're our go-to resource for Florida. And so that also puts, again, more burden if the people who are tracking this nationally are looking to me and saying, we're looking at your dashboard again. It's just, it's a heavy burden because it really is, this is a one-man show. I don't do this with anybody else. I sit in my office at home and I do this. So it's kind of a strange thing. But the other big thing is the importance of being one of the reliable sources of information and serving the public. So what I mean by that is, before this, epidemiologists don't just go on the media all the time. Media didn't really care a lot about public health professionals unless there's some sort of a COVID-19 kind of scenario. So I think before this, I may have talked to the media a handful of times. One of the studies that I had from my dissertation research got some attention in Houston, and I talked with an actual in-print newspaper, but that was pretty much it. So early on, my study on kids got a lot of attention. And so as you can imagine, the media reached out to me, and these were just some of the headlines when I was on the air on local media. Study finds that kids may be undercounted, so focus on kids. Big mistake for Florida schools to reopen this year. And that was at a time, early on in the pandemic when that was the obvious decision. We shouldn't send kids back to school because we were starting to see these big spikes. But all of the stories at the beginning, when the media were contacting me, it was about kids, because that's my area of expertise. That's the study that I published. But since making this dashboard, this is a guy from my local Fox 13 affiliate, he actually did a story and he used my dashboard to explain a lot of what was going on in Florida, which was kind of cool. But then things evolved. So now when they found errors in the Florida Department of Health data, or when they changed the way that they were reporting information, or when they felt like, oh, they're not reporting information on non-Florida residents, or, they posted this report about schools and then they took it off. Now I'm getting contacted about all of those stories as well. So these are all stories that I had a say in, because now that you're developing a dashboard and people are looking at it, now you're seen as the go-to resource for understanding data, which is, it's a good thing. I feel comfortable in that role, but it's also a little daunting that now you're starting to say things about the, age groups and people that I don't often study. And so it's been an interesting ride. And then, of course, the big thing was, so for all of these local stories, the way that they do it is the reporter contacts you and they bring up like a Zoom thing and they record the meeting just like this one. And so when they record the meeting, though, they're asking you a bunch of questions. And if I sound like a bumbling idiot for 5 minutes, but I say like 25 seconds of really enlightening things, they can edit it out and make me look very smart, right? But my first live on-camera interview wasn't with a local news outlet. It was on CNN, which is very, very weird. So again, since many of you may not have been through this, what made it so weird is obviously, you're nervous, you're going on CNN. It looked like CNN was going to make it look as though Florida was doing something kind of, that you can see it in the title there, right? Skewing the numbers. I mean, let's be honest, that's why you're on CNN, because it's eye-catching. There was a story that was published and they wanted my take on it. And they thought I was going to throw Florida under the bus as though they were skewing numbers, which if you watch the interview, I did no such thing. But when I'm preparing for that interview, I'm sitting just like I am right now in my office. There's nobody around me. My wife and son are in another room, and I'm just sitting here. And I thought I would be able to see the anchor, Brianna Keeler, on the screen or something, so I feel like I'm talking to somebody. No, you call into this booth, and you're waiting for 15 minutes, and they're constantly coming in, bring your monitor closer, change the, they want the shot to be good. They're testing your audio. But then they just come on and they say, okay, 30 seconds. And you can just hear the show in your earpiece. And then this person comes to you and they're speaking to you, can't see them. And so, you're told to look into the camera, even though you want to kind of look down at maybe notes that you've taken. It's just a very surreal experience, because you're now talking to people who are watching nationally, but you're just staring into a webcam with nobody else around you. So really unique experience. But the big thing that I would say, and this is just my own, this is how I choose to be. And this is a good lesson for how you communicate with individuals if you choose to be this way. I think why I actually get a lot of people, if you look at me on Twitter, it's easy to reach people who think like you, right? And I'm kind of talking politically, right? If they're on the left or the right and you're on the left or the right, it's easy to get those people to listen to you. It's really hard to get people on the other side to listen. And those are the important people to reach, because if you're just, it's almost like a confirmation bias. If the only people listening to you are people who already think like you, what are you really doing to change people's perceptions or to bring real data to people who are trying to struggle to find it. I stay very apolitical. For me, and I have a political opinion like everybody else, but I stay apolitical. It's all about the data. Here are the data. Here's how I, as an expert in epidemiology, interpret what's happening. I don't say Governor DeSantis is bad or good. I don't do that. Now, I will call out organizations if I think that they should be supplying better information, but that doesn't matter if they're left or right. And I think that's why I get a lot of people who may disagree vehemently with me, but they pay attention. They rely on my dashboard as a source because they know that when I give them information, there's no spin on it. So again, I want everybody to be passionate, and part of passion is politics. But I think it's a fine line that you have to walk if you want to reach different people and you really want to keep it about the information, especially in a pandemic when everybody's struggling, they're suffering. They want to return to normalcy. And so again, I don't mind. I like disagreeing with people because nobody has all of the right answers with this pandemic, but I want it to be a discussion about the data and maybe, interpreting what we're seeing differently. I want to battle the misinformation bandits that are out there. And again, the only way that you can do that, I think, is to stay as apolitical as possible. And so more recently, I've been asked to kind of make sense of the COVID-19 data when there's a spike in the information, like we had one of the labs in Florida give a big dump. And so you saw cases rise from like 2,000 to 7,000 one day. People freaked out and they're like, what does this mean? And obviously, it's good when you do your homework and you're able to explain, look, let's calm down. This was just a dump. The cases actually occurred way back in June and July. So there's really not as much of a blip. So again, it's nice to be a resource for people. And then hopefully everybody here has learned, if you're in public health, when the CDC came out with a report, people were misinterpreting it. I think a lot of that was because the misinformation, people were pushing a narrative that only 6% of all deaths are due to COVID-19. And that, of course, was absolutely wrong, and so I was asked to go on a couple of newscasts and explain it. And of course, I gave the example that if somebody gets, no comorbidities, right? They're pretty healthy otherwise. They get the virus. Unfortunately, the virus leads to them developing sepsis and maybe respiratory failure and a heart attack. All of those things, the respiratory failure, the heart attack, the sepsis, those should be listed as contributing causes of death on the death certificate, right? But because those are listed, it doesn't mean that COVID-19, that this virus didn't cause that sequence of events. And so again, just trying to place things in context so people can interpret the information accurately. I've already alluded to the fact that I've gone on Twitter and I tweet a lot of threads. Again, when I find something that's important or I see that a lot of people are misunderstanding, like in Florida, we report, or let me not say we, the Florida Department of Health reports 2 primary measures of case positivity. The National COVID Tracking Project, which also reports on Florida, reports yet a 3rd. And so I present all 3 of those on my dashboard, and they tend to trend similarly, but they yield very different values. And so people are like, well, which one do I trust? And so you try and, produce some threads to help people to understand the information. And so what makes me feel good, all of this effort, it's really, I don't sleep much because of this, because I'm very busy during the day, with my normal job, and then trying to upkeep this and tend to people online. And, I'm getting tons of emails thanking me, but I also get tons of emails. Can you explain this? So it's a challenge. But when I get things like this, like I've been using your COVID-19 visualizations to update the faculty at, sorry, this is UF. Let's just say it's FSU. But UF Health in Jacksonville, and it says later that this is the chairman of different departments. These are important decision makers who are using my dashboard. And it's not anything special. It's because I allow them to drill down and look at specific populations. Makes me feel good. I've been invited by school boards to help with their decision making. And they say that, yeah, your dashboard really helps us to dive deeper. And maybe we don't know all the right decisions to make, but it helps us to better understand the data. So again, as a public health person, since I'm speaking to students who are going to be public health professionals in some capacity, this is what it's all about. When I publish quite a bit, right? I've got over 150 papers that have been published, in the past several years. That's a lot of papers. I don't know what happens to my papers. Some of them I do. Some of them are pretty high profile. Others I'm like, well, who's reading this? Is it changing the way that they do research? Is it impacting people's health? Sometimes you can feel like your research goes into this abyss and then you don't know the genuine impact. I've never felt like I'm impacting people's lives more than I have been with this whole COVID-19 experience. And so what's next? This is more like about where are we? I think we've still got a lot of work to do. I'm going to continue maintaining my dashboard. I think all of the The indicators, as I mentioned earlier, have been trending in the right direction. I think we've gotten community spread down to a much more comfortable level. I think it's going to be a while, though, before we see what the impact of maybe our actions on Labor Day, what that's going to result in. Because the big thing, so what I'm seeing in the data now, and again, if we have time or if people are interested, I can actually show you this on a new visualization I just put on my dashboard today. What we've been seeing more recently, certainly you've heard at FSU, there's been over 800 cases, and that was just a day or two ago. We're seeing as children and young adults are returning to K through 12 schools, to daycares, to college campuses, we're seeing an increase in the number of positive cases. That's expected, right? That shouldn't have been a surprise to anybody, because we're trying to weigh the benefits and risks, right? There's obvious benefits of returning to schools, especially for young children. But what's the risk associated? But we knew that there would be cases. The problem is when there's too many cases at one time, a lot of people like to say, well, young, healthy people like you, I'm not going to put myself in the young category, but you're young and healthy. The likelihood of something serious, yes, it happens, but it happens from the flu too. So the likelihood of really severe consequences of this, it's really minor. The problem is when you have high community spread, students don't live in a bubble. And so they tend to interact. If you're in K through 12 schools, you live with your parents. And if you're socioeconomically disadvantaged, you might live in multi-generational families with grandma and grandpa who are high risk living with you at home. So after a cycle of increased community spread, even though it might be in young people, it tends to spread to more vulnerable populations. So I'm hoping that does not happen, but we're still another 2 to 3 weeks out before we realize if that is the case, if we start to see a rise in infections in older populations. And then, of course, if we do, it's probably only a matter of another week or two before we see increased hospitalizations. And so I'm not saying any of that is going to happen, but I'm saying that's why I have my dashboard. That's why I monitor this information, because I want to see what's going to emerge out of this. This is the pride and joy, any presentation I do. My son is almost 2.5 years old, Gabriel. He's just everything. He's what gives me tons of energy as well. And so with that, I'll take a pause and see if there are any questions. If not, I'll go to the questions that were pre-prepared. Let me try and stop.
Let's take a second. Thank you, Dr. Salemi, for joining us and being here today. Anybody's got any questions for him?
I have a question, but if anyone wants to go ahead.
Wait, oh, sorry. Wait, Krista, you go.
Okay. I was going to say go ahead, but then we'll be back and forth the same time. I was going to say, and it's a little similar to what you were saying. It basically ties into how when you presented on CNN, they kind of wanted to hear you say bad things about Florida, but as a researcher and a scientist, you want to remain apolitical and to the data, which is the best way to go always. Mm-hmm. But I want to say, how do you feel, and this was just through CNN, so how do you feel about the media and larger outlets, so not just at the state level, but at the national level in Washington, D.C., why there is this pressure, or if it exists, on scientists not to really say the truth if it doesn't fit the narrative of what politicians might want?
Yeah, I mean, it's an excellent question. So going back first to my impression of the media, it actually surprised me. I've worked a lot with the local media, so specifically in Orlando, in Tampa, in Sarasota, in Miami. Those are the major ones. I've spoken to a lot more than that, but those are the major ones. And I must say, I'm so impressed, because they are genuinely, it's not this sensationalism, right? Most of it, now, they have to sell stories, right? But the local media, I feel like they don't just chase the big stories. Like the reporters that I've interacted with, they are so appreciative of being able to talk to the experts, and they try and talk to a lot of them, and they try and get the story right. And again, it's a small sample, but the ones that I've interacted with, I'm so impressed with. And so I've also talked to Bloomberg, I've talked to Rolling Stone, I've talked to a lot of non-TV news outlets, Newsweek. And when they've done their stories, again, by and large, my perception of them has been wonderful researchers in their own right, trying to get at the truth. And their ultimate reports are not sensationalist. The 24 hours news cycles, and I'm not just going to talk about CNN or MSNBC or Fox News, right? We'll put them all together. 24-hour news cycles they exist for things like this, for hurricanes, when you really need to cover the news for 24 hours and keep people informed. In the absence of that, what happens? Like, you got to fill the time and you got to keep people tuned in. And so, what's best for them is if you have a story that's eye-catching and factual and, but it also is a little bit sensationalist. I want to be fair to them. I think it is important if, as they read in this Orlando Sun-Sentinel report that they contacted me about, it did seem like Florida might be skewing or intentionally skewing the numbers, right? That's the way that the story was kind of written. So it's not that they were searching for that, but I'm sure that's what enticed them to interview, because that would be a big deal when they're covering national news. If Florida is trying to hide the truth from people, that's a problem. And I think they were also, when I said, well, I don't think it's that. I think it was a communication issue. I think it was poor communication on one of the issues. And then the other issue was I thought that they were combining information from tests that they shouldn't be. But I did not think you could jump from that to thinking it was intentional. In fact, if it was intentional, it would have been stupid, right? Because there would have been way better ways to mislead people than that, because it would have resulted in a minor difference. So, but when I was reporting on the facts of the matter, it's not like they were digging any deeper, right? They just said, oh, okay, thank you for enlightening us. But, obviously they tend to pick the same kind of people who are, and whether you say fair and balanced, I'm not going to talk left or right. But if you're looking at MSNBC and you're looking at Fox News, it's alternate universes of reality. If you're watching those, sometimes, because I try and watch both of those just to understand the perspectives, sometimes you will get the same 20% of factual information and then the spin occurs, right? So anyway, in answering your question, I think I've been mostly really impressed with reporters, but I think there are bad ones out there who are just spinning a narrative. They could care less what the evidence actually says. They'll use any single story to prove their point, confirmation bias. And most of the people who are watching biased news networks are like, yeah, they want to hear what they want to hear. And so they're never going to be upset with that. And so that is kind of disappointing. But the one thing I encourage everybody, the one thing I feel like I was blessed with is I could give a damn what you think about, if the fact that I'm staying right in the middle and I'm not getting political and people want me. I mean, I can't tell you how many people on Twitter are like, they'll reply to something and it's like, and from both sides, right? It might be, DeSantis is trying to kill us, or see, people don't give DeSantis enough credit. You see both. I try to just not respond to that. Sometimes I will, and I'll say, look, you can't go that far. You can't say this was intentional. I will try and correct people, but I can't do that all the time. But I don't bite on those things. I stick to the facts. If people want to understand the data better, like that, I don't know. To me, as a scientist, if you want to be well respected, you've got to be that. You can still be passionate in your politics and you can vote that way and you can disagree. And, if you disagree with a lot of what the president or a governor said, you should be able to do that. But again, I think it's all on how you're presenting information. The research that you do should not be biased by your political viewpoint of the world. That's just my opinion. It shouldn't be. It should be, what do the data say? You present the information to people and then let them put their spin on it, because they certainly will.
So I had a question about, so you are an expert in what you do, and you compile all this information and you put it out there for everyone to see. And obviously, once you make something public, like you put it on YouTube, Twitter, whatever, you'll always get those negative comments, those people that just absolutely deny everything that you say and what you stand for,
yes,
even when it's factual.
Yes.
So how do you cope with all of that negativity? And also, how do you cope with just being the expert in what you do and seeing that the CDC is saying one thing, but then the Trump administration is saying a completely other thing? How do you cope with that?
I mean, just brilliant questions. So when I went on CNN, and this kind of blew my mind. So I had gotten a little more active on Twitter. So I don't have a ton of followers now because I'm not that interesting. But I went from 30 followers to, I think at the time that I went on CNN, I was at 1,400. So, I had a lot of people who started to follow me because of the dashboard. This is how crazy it is. I'm a nobody, right? I really am a nobody at the end of the day. When I went on CNN that night, I had people posting to my Twitter account. You know how if you go on Twitter, sometimes it'll like block a message that it thinks might be sensitive. People were already like posting stuff like I'm tied to Nazi groups, like immediately trying to discredit a nobody. It's not like I'm one of these regulars. Like I used to sit next to a guy named Peter Hotez, who is always on CNN and MSNBC. I mean, he's one of the foremost experts. When I was at Baylor College of Medicine, I used to sit next to this man. Like he's always on there. I get that. I went on one time on the national news and immediately false information just trying to discredit me, right? They didn't like what I was saying, even though it really wasn't even political. So coping with that at the beginning, I'm like, holy cow. And I even had somebody that I was interacting with on the COVID tracking project who was deathly afraid to get anywhere in the public eye because of that very issue. And she was like, are you seeing the things that they're posting about you? And so, I looked into it and initially it bothers me, but then I'm like, okay, if you're going to believe this about me, then you don't know me and you're probably on that side. Like, you kind of let it go. But I will say, I've got some other colleagues, one who is, and I apologize again, at UF. She's an amazing biostatistician. Her name is Natalie Dean. She's doing amazing research. She's got like 70,000 followers. She's bringing really good information to people. She's also does it in an unbiased way. The way that I have seen women scientists attacked, it's so much more egregious than, and again, this is just based on my observation, but I have a feeling it's true. The way that just thousands of tweets that are in response to just some scientific information and the depths to which they'll go, death threats that are received on their voicemail. Like I've been fortunate, again, because I'm a nobody. I've gotten emails like this one guy emails me like every other day and is like, oh, you're misleading the world. Like, and he always like doesn't even make, it's a lot of rambling, right? But that's easy to ignore. When you get like the dean of my college, Donna Peterson, she told me, when I told her, oh my God, I'm on the media, I'm not used to this. And she's like, you got to keep doing it. You got to bring real information to people. She gets death threats all the time. And I don't know how I would deal with that, because I think it would just, if it were just me, not a big deal. It's very easy to find out where I live. It's very easy to find out information about me, my wife and son. Like, that's what would really scare me, I think, if it got to that level. Thankfully, it has not yet. But yeah, it's interesting. It's just sad though. It's sad that people feel like they need to completely fabricate information to discredit, like just let the data say what they're going to say. Like, is it, but I will say, I mean, these people are incredibly well organized too. They have very official looking websites. They present information in a, like, if you don't know any better, in a seemingly cohesive manner. So, I mean, it's very, very easy for people to be fooled by people who are just spewing a bunch of nonsense. And then to your other point of, you're now the expert and you're going on all these things, the one thing I would encourage you, and this is part of what makes it challenging to be a scientist nowadays. So if somebody asks me a question that I don't know, I'm not going to feel obligated to answer it. I'm going to say, you know what? That's not my area of expertise. I don't need to answer every question, because if I answer one I really don't know the truth about, like that's problematic. So you got to be able to say when you don't know something. And we're cautious as scientists, nothing is definitive evidence right now about COVID-19, or we'll say very, very little is definitive, no doubt, right? So as a good scientist, you're always saying, well, based on the information we know right now, right? And then a good scientist is also, I might change my mind tomorrow if good evidence comes out in contrast of what I thought today. You've got to be able to do that, especially in a pandemic like this, because the information is emerging so rapidly. But people who are spreading misinformation, because it's fake anyway, they can say it with 100% certainty. They don't say, well, no, they just say this is fact, and they're misleading you. And that certainty, that level of, I know the truth and people are hiding it from you, that's so comforting to the person who's out there, who's been dealing with COVID, who may have lost their job, who wants to get back to normalcy, who doesn't want to have to wear a mask, whose children should be back in school. Like, right? It's very comforting for this person to say, see, they've been lying to you this whole time, and I'm positive of the truth. And it's exactly what you want to hear. So it's hard. It's really, really hard for scientists to battle that. And then you've got, so I won't say any specific people in the government, but then when you have people in the government who are dogging scientists and saying that scientists are, committing acts of sedition again, like, Obviously that rings true to people, and some people want to believe that, and then they don't trust scientists at all. So I guess that's part of my charge, right? Is I want to be that unbiased person who presents the information, who's very, we've lost all semblance of courtesy. I kind of joked with younger students, obviously, your questions show your maturity levels here, but the ways in which we communicate with each other has gotten so short, and it lacks any politeness. Like, even when people come at me and they misinterpret the information and they're very rude in their response, I always rise above the fray, and I'm very cordial with them, right? And people will direct message me and say, why don't you just call that guy? And I'm like, because you've got to, if people are going to come to you and they're going to respect what you're doing, they've got to believe that you're there to just present information. You're always going to be courteous and polite, and it's hard as hell, right? I'll hit the send button on something that's really nice, and then son of a bitch, I'll be cursing under as soon as I'm done with everything, or my poor wife hears me complain all the time about those things. So, it's how do you want to be as a scientist? Excellent questions. Hopefully in that rambling, I answered some of them. Another is, so, if we're waiting on more, I do have a couple more that were sent in. So how well did the MPH program at USF prepare you for your career? So I'm not dogging any program. I don't think an MPH, like if you're just talking about my coursework, it's good information. It's good topical knowledge. Like I knew a lot of facts, but I did a hell of a lot of work on my own to try and learn skills. That's my opinion of a master's degree, right? I think you need to come out of a master's degree with this new budding knowledge, this critical thinking capacity, but you need to come out with some skills. So even though I wasn't getting a ton of it in my coursework, I sought out the graduate research assistantships, whether they were paid or not paid. I tried to learn software and these visualization things or data analytics. I tried to just learn things that would make me stand out above other people, because at the end of the day, unfortunately, everything is a little bit of a competition, right? And so if I wanted to go for a job and 13 students applied for that job, I wanted to be able to say, yeah, but I know this and this and this that most other people wouldn't have known unless they worked on it on their own. So it was the building blocks, right? It helped me to get some foundational information on epidemiology and some of the other public health disciplines. It taught me how to think more in a population sense. And during the course of my MPH, I took it upon myself to really start building my skill set. But that only got me part of the way. And it was a hard decision as to, do I really want to keep going to school and get a PhD? Because at the time I kept saying, I don't want to be the person in charge. Like, I'm a really good worker bee. I'm the person who, if you give me what to do, I can take it and I can do it and I can do a phenomenal job. But don't ask me to be in charge of everything and to dictate what other people, like, that wasn't what's, I thought was going to make me happy. And so I had gotten a really good job offer, really good for only a master's degree at the time that I was graduating with my MPH. It was with the American Cancer Society. It was making very near six figures, which again, for an MPH, and it was data analytics. And so it was perfect. But I knew if I didn't do my PhD immediately, I wouldn't do it. Once I got the money, like it just wouldn't make sense. And so I sought out the advice of other people. And, it was such a close call. As I started to go through the doctoral program, I started to realize, like, oh, I'm kind of sick of taking orders from people who I don't think they're doing things the right way. So the more I learned, the more I developed my expertise, the more I wanted to dictate and control things. Not because I'm a control freak, but because I thought, well, I'm building this repertoire where I can do some really good research, and I don't always want to be taking direction. I want to be able to, design really good studies that impact people's health. So MPH starts to get you there, but it all depends on what you want to do ultimately in your life and in your career. I would say it would be insane to go through and jump through all the hoops of a PhD if you really don't need a PhD to do the things you want to do, right? If you want to go into academia, PhD, right? If you want to do certain things in this world, PhD, it's your union card. It's what gives you that level of credibility. They tend to not interview master's people. And that's not because people with a master's degree aren't way smarter than I am, but they want a doctor, right? Whether it's a medical doctor or a PhD, it adds that level of you've at least gone through a certain number of steps to gain some expertise. So, yeah, MPH started the process, but wow, I'm very different than I was when I graduated with my master's degree. And then the other one question I got in writing is, let me see if I can move this out of the way so I can actually read it. Sorry. So considering Leon County as becoming a hotspot, how do you think testing should be handled going forward? And besides social distancing and wearing masks, what other action can it, can an individual take? So Leon County, yes, there's been a lot of cases, in colleges. So I've looked at my dashboard. It's being driven almost entirely by the 18 to 22-year-old population. Again, this isn't necessarily surprising when people return to college campuses. I actually hate stories that have come out in the New York Times blaming students. If we make the decision as people who are in these universities to bring students back, we're obviously asking for students to be as responsible as they can. But, for students to be students and sometimes maybe relax those things like that, that had to kind of be expected. It is sad because I think, unfortunately, there's a high proportion of the population that does not believe that things like masks do anything. And so in the absence of definitive evidence, which it's hard to design a study in the middle of a pandemic that, like a clinical trial to evaluate mask wearing, like some of those designs are just implausible. And so it'll always be easy for the detractors to say, yeah, but there's no definitive evidence. I actually just read something yesterday from the New England Journal of Medicine. Hopefully all of you know what variolation is, when a good example is like the seasonal flu. So if you get the flu vaccine, right, you may still get a form of the flu, but if you get it, the theory is that it'll be much less severe than it would have been. So again, not all vaccines are going to prevent you from getting the flu. In large part, it may, but if you get it, it'll be less severe. And they kind of think that masks, yes, it's not surefire, especially if you don't wear it right, but they think that you might get lower doses of the virus. So even if you contracted it, even if you're a more vulnerable subgroup, if you're older, you might get a less severe version of COVID-19. And so anyway, testing, I think in a pandemic, if you talk to most experts, you need to do more testing. I'm so sick of the narrative that, well, if you didn't do any testing, the testing causes cases. Testing doesn't cause cases, right? The cases are going to be there no matter what. It's, are we going to be blind to the cases or are we not? Now I get it. If tomorrow you told me 100% of people who contracted this virus are going to be asymptomatic, they'll never have any serious outcomes, I wouldn't care about COVID-19 anymore. Nobody would, because it doesn't cause severe illness. But the fact of the matter is, it does. And so we need to pay attention to it. And the only way that we can understand how it's spreading is to do more testing. And the big important component of that is, from the evidence that exists, asymptomatic and pre-symptomatic spread occurs. Even though you may not have symptoms, there is an infectious period after you get the virus that you can spread it to others. And so the more people that are getting tested and being aware of that, we can use contact tracing to make sure that they're not spreading it. Because again, you might say, I'm not around anybody who's vulnerable. It's all younger people and it's, likelihood is low. It's worth the risk. But I promise you, the people with whom you might be engaging, somebody is around more vulnerable populations, or you go out, you interact with somebody, the virus has a way, if there's enough community spread, no matter who that is in, it has a way of getting to the more vulnerable populations if you wait long enough. And so, I expect most of the major colleges to be a little bit of a hotspot. The question becomes, is it going to get into more vulnerable populations? And besides social distancing and wearing masks, what other actions can it, I think that's the best way. Stay outdoors as much as you can. Try and avoid indoor settings. If you're going out to eat somewhere, try and seek outdoor environments. If you're in the car with somebody else, roll the windows down. If you have to be in an indoor setting, try and roll the windows down. Get as much fresh air. Try and avoid the indoor environments exclusively as much as possible. And certainly, if you're unable to do that and you have to be indoors, wear a mask, wear it appropriately, and try to social distance from one another. Again, based on all the evidence that we have, those factors are very important at reducing community spread. We are a long way from this whole notion of, and I don't think it's a popular thing to say, but this whole notion of just let it run wild, achieve herd immunity. We're close to that anyway. We're far away, regardless of where you put that marker, 40%, 60% of the population to achieve herd immunity. We're still far away from that. And in order to let the virus run wild to get there, a lot of people would die. And so that's what we're trying to avoid. It's not just about flattening the curve, right? It's about trying to prevent as many vulnerable populations from getting the virus as possible. So that's the only questions I had written. But again, I'm happy to take any questions about anything.
Question.
I have a specific question more about MPH programs.
Yep.
So I'm starting my process of narrowing down my list. I'm going to start applying to schools within the coming weeks.
Mm-hmm.
And I've seen a lot of people say that an MPH program, because I'm trying to decide if I should stay in state, you know, the tuition's lower, or because there's a lot of programs that are a little more expensive out of state that really tailor to my interests.
Yep.
So do you agree that like an MPH program it's an investment in yourself?
Oh, I mean, it absolutely is. I mean, you know, it is a stepping stone to, you know, it's really hard because I'd be lying. And so I mentioned at the beginning of this talk that I had gotten accepted into medical school and I decided I'm going to get an MPH and then a PhD. But I'd be lying if I said I knew exactly what I wanted to do with that. So a lot of this is just, again, trying to say, where do I want to be? What are the kinds of things I think I want to do to impact people's health? You know, because I think that's why a lot of people are on this call today. And saying, what are the stepping stones that I need to go through? MPH is absolutely an investment in oneself. And so, you know, if I lived in Florida, I can't speak for all programs, but I do love the USF program. You know, I think, and I think it's only getting better. You know, one of the big pitches, so I was doing my interviews at the end of last year to see if I was going to be the person that they were going to hire. And there were a lot of ideas, you know, like there are some things I think we can do better. So for example, I think everybody, hopefully, has heard of data scientists, right? Data scientists are not public health experts or epidemiologists, you know, but they are phenomenal with data. And the growth of data scientists and the growth of machine learning and artificial intelligence, there are a lot of really cool tools that are underutilized in public health disciplines still. They are used extensively by data scientists, but sometimes they're just very good at, you know, running the data, but they don't use the appropriate theory or the appropriate study design. So the blend of those two worlds to me is important. So I want to kind of upgrade our profession, get us more technologically in and using tools that are not just because they're fanciful, but because they might be better if we're developing like a predictive model to try and predict an outcome or help a clinician make a decision on what strategy to take. Do I do surgery or do I do this non-surgical approach? And I'm using this predictive model. If there is a tool that does a better job of developing a model that does better prediction, like we should be using those things. So I think, you know, at USF, the program is great. I think you can, if you're in state, you're going to get a hell of a return on your investment. But certainly there are a ton of programs across the country that offer different things. You know, sometimes the decision of where to go, maybe not so much at the master's program level, but it certainly happens, is who is there. Can I reach out to somebody? I get a lot of emails all the time from prospective MPH students, especially since my name is in the news quite a bit now, and they'll reach out to me, you know, I'm really interested in maternal and child health too. Do you think there's a possibility that you would have a graduate assistantship? Or, you know, a lot of this is, what is my life going to be like outside of classroom? What kind of other opportunities? It is not good enough, in my opinion, to go and sit in the classroom and that's your MPH experience. Even though it's a lot of hard work, you've got to go above and beyond. You've got to seek real world, you know, experiences. Even again, but most of these programs will have a field experience kind of thing, but you've got to go above and beyond, really be passionate about not making this a job, making this a career, something that you really like to do. So yeah, it's certainly an investment in oneself. I was very blessed. I worked really hard at the beginning of my MPH program to find fellowships, but I am Latino, and so I was able to find two different fellowships, one that was called the Latino Fellowship, the other one that was called the Dolores Auzain Fellowship, which was for Latino students. And, you know, I had, I would say, all but like $300 of my master's and PhD entirely paid for. And so I'm blessed. I didn't have to accrue a lot of debt. That has to be a factor that you weigh, especially in kind of more uncertain times that we have now, is how much debt do I want to accrue? But you're going to have to invest. You know, all of this is an investment, but wherever you go, seek out graduate assistantships and fellowships. And, it's a ton of work applying. There was a few things that I had applied for well before I actually got those fellowships. And it was a lot of effort, and it was just a series of no's, but then you hit the home run and you get the yes. So anyway, again, rambling response, but all of this, the things that you want to do, like I'll give you another example. I obviously, as a professor, I make more than I did as a student, but I still invest in professional organizations that can cost several $100s a year to be a member, because it's professional development and it's contributing to your career path. And so, a lot of what you do from here on in is an investment. And again, no better example than what I've talked to you about today. I don't have to do any of the stuff that I taught, like this dashboard. It's a lot of work. It's not rocket science, but it is a lot of work on a daily basis. And I'd much, sometimes, some days, I'd much rather just sit here and do my work instead of answering 4 reporters' emails and then going and doing an on-camera interview. Like it'd be much easier to not do those things. But why are we in this business if it's not to better serve the public when we have the opportunity to?
Thank you.
Of
that
course.
was really helpful.
Good.
Jason, I want to touch on something you just said too. I think
sir.
it's really important that you do have a connection with the faculty and the other students. So the best advice I can give to anyone thinking about any graduate program is to visit the school, get to know the faculty, the culture, because you may find that regardless of how they're ranked, regardless of what they offer, that you're just not a good fit. A good example, anecdotally, a friend of mine was invited to the sociology program here with my cohort, but she also got a full ride to UNC Chapel Hill, which is a phenomenal school. We all know where UNC Chapel Hill is. But when she went, she found the culture wasn't really useful for her to be successful. They were very competitive. There wasn't a culture of cooperation, and that's really what she was looking for. So she ended up becoming a year behind and then came back to FSU and then, moved through and graduated with her PhD. But she lost a year because she attended a school that was higher ranked and chose it for those reasons. So I think it's really important that you do make connections with people that you can work with and would want to learn from.
Yeah, phenomenal recommendation. It's, I can't tell you how many. So I always joke as an epidemiologist, when somebody asks you a question, your answer is almost invariably, it depends. Right? It depends on so many characteristics, or it's not a one size fits all. I've said that so many times for coronavirus because it's different in every county, every zip code, depending on what you're doing. It's the same thing. Like there's a reason that there are different schools with different cultures and different people going there. Some end up making mistakes, maybe going there, but like there's just something that fits your personality. And so, I'd be lying to say if my choice of USF, I was already, that's where I got my undergraduate, but I was born and raised in Tampa, and, the culture fit. I didn't investigate a lot of other places, but what was important to me at the time is being around family and friends. Like that was a priority for me. It may not be a priority for other people, but certainly if there's one thing I would have done better. So I think I did a lot of things right in my master's program, but I was always afraid to bother people at the beginning. And so now I encourage people to bother the hell, even though, sometimes, don't get me wrong, if I get an email from the same student, 6 times in 2 days because I just haven't had the time to respond yet, it's a little bit of an aggravation. But if they're professional, if they're, if I can tell that they're passionate about something, I'm 100% on board with that. So I wish I would have been a little more forceful and not always felt like, oh, if I would have reached out to this person, I'm going to be bothering them. They're way too busy for somebody like me. Like, no, you got to go out, and you never know. What is it they say? You miss 100% of the shots that you don't take, right? You can't be bashful. You email people. The only thing is, at least for me, the way that you communicate matters so immensely. If I get an email from 10 students, and 2 of them are emailing me like they would text somebody, I'm not even going to respond to you, right? Because there's a certain level of respect that should go both ways, right? I'm not really curt in my responses. I may be brief, but I'm always respectful no matter who I communicate with. So I do think the way that you communicate both orally and in email communication is immensely important, but Don't be bashful to reach out to people, ask them, and again, it's a fine line, right? You don't want to come across as forced, because there are students who are genuinely interested in the research that I've done. They've looked me up, they've read some of my studies, and when I talk to them, they're genuinely interested, they're passionate about it. Others, it's like just a show, right? You're not being real. Oh, I read this paper and this paper, and we would say you're being a kiss ass, right? Be genuine, right? Don't be afraid to reach out. Be passionate. Be energetic about what you do, but be yourself. Be genuine, because if you're yourself, you're going to find the areas in which you fit the best. And so, excellent recommendation, Ben.
Thank you. Anybody else got any questions for Dr. Salemi?
Yes, I have two, if that's okay. I don't want to take up too much time.
No, and if people need to drop, like you're not gonna hurt my feelings. I'm happy to stay as long as people actually have questions.
Yeah. So my question would be a little more, if you could discuss more of like pre-COVID, your day-to-day work in like maternity and pediatric health research.
Yeah, fantastic question. So I'm not very good at being concise and short, but I'll try and give you the bird's eye view. So when I graduated, I had a decision to make, like we all have a number of decisions to make. So my decision at the time was, do I want to work for a college of public health, which is going to be people like me, epidemiologists, or do I want to go to a college of medicine? And I thought at the time, I got an offer from a really great medical school, Baylor College of Medicine. And I thought, I just need to be around people who think differently. I've been in Tampa my whole life. I've been at the same university my whole life. It's a lot of just the same way of thinking. And so my thoughts were, well, I can be a useful commodity to them because I'm public health. I'm going to work with other public health people, but it's going to be driven by the medical profession. And so I thought I can learn a lot clinically, and just be in a different environment. I needed a change. And so what was very interesting, just showing you how you need to be malleable to the situation. So the life of a PhD academician is both great and horrible at the same time. There's a lot of flexibility in what you do. You can have a lot of independence in what you do, but it can be a challenge, and especially with getting grants. So my view of that first job going into Baylor was, okay, everybody's going to be way smarter than me. I'm going to be this little person, and I'm going to have to just, publish my studies and get grants. And that's the way I've got to survive. Well, when I get there, I'm in a big department at Baylor. It's the second largest department. It's got about 200 faculty. Most of the faculty in the department are medical doctors. And I would say about 50% of those medical doctors did have dedicated research time. The other small proportion were public health people like me. And so when I get there, the chair of the department, who, and I'm going to be absolutely honest, I think the reason I got this job was because they actually wanted one of my colleagues as a vice chair. And that colleague said, well, this guy's incredible. You've got to hire him as well. So I don't even think it was me. I think I looked good on paper for somebody who had never had an academic position, but I don't think I got the job at such a good institution because of that. So I don't think the chair really even cared about me. But as I started to sit in meetings with them, and we started to discuss grants and improving the publication volume and quality, those skills that I told you I developed, being I'm an epidemiologist, but I've got graduate certificates in both biostatistics and applied biostatistics. So I not only know how to do the data, but I know how to communicate the data very effectively, which is immensely important. Again, oral and written communication, my God, if you're not good at them naturally, practice, because that's how you really get noticed. So anyway, the chair of my department asked me after about 3 months, he starts to take a real liking to me, and he's like, look, I know what you have as an idea of what you want your career to be like. Baylor College of Medicine has this new track to promotion, and it's called the team scientist. So instead of you being this independent person and going after grants that you lead, I would love for you to help us just publish like hell. I want you to help a lot of our faculty, like make our grants better. You're a great methodologist, make our grants better, but I don't want you to be the principal investigator on those grants. I want you to be just a person. So instead of going after, again, like 3 or 4 grants a year and trying to be the principal investigator, I was helping to write like 15 grants a year, but I was not going to be the PI on any of them. I did end up having a few that I worked on the side, but I had to change what I thought I wanted to do, and it turned out to be just immense fun. So what did my day look like? Well, at a medical school, what was very different is I did do a lot of teaching, but not in the formal sense. So we had a postdoctoral fellowship. So there were 5 postdoctoral students who ended up reporting all to me. And so I did a 3-hour curriculum with them every single week, and I was each of their mentors, right? So I did some teaching with my postdocs, and then we got this major grant called the Center of Excellence in Health Equity. And so I would teach a lot of doctors, there's 20 a year. I would teach those doctors a lot about research and specifically racial disparity. So I had a teaching component that was probably 15 to 20% of what I did. I spent a lot of time looking through data, sitting in front of a computer, operationalizing variables, doing data analysis, writing manuscripts, and getting those manuscripts published. I spent a lot of time doing research, writing grants, evaluating methodology. So a lot of my time was in front of a computer. At Baylor, I had very little one-on-one interaction with patients that were a part of our grants, because that wasn't my role. We had people who were recruiters and study coordinators who actually did those kind of things. So it is an immense amount of time thinking and writing and analyzing. That was my experience. The thing that I got the most joy out of is the interaction with my postdocs. When I would get together in these brainstorming meetings, like really sitting down and running thoughts among your colleagues, the ones that you end up liking, and really just thinking. Like, I love the challenge of, damn, here's something that we hadn't thought of, and trying to struggle through that. Like, that's what I love about the discipline, is the daily challenges in either analytics or in trying to solve a problem or in the methodology. So that was kind of my life. And again, I had to shift. And so I was very, really productive. In under 5 years at Baylor, I published over 100 articles, was able to get promoted. But I wanted to change, right? As much as I like being around the physicians, I wanted to come back to a college of public health, because I ran into struggles that not enough people thought like me. And I was running into like, well, why don't you understand this? And so got a little frustrated, wanted to come back home, wanted to teach more formal epidemiology classes. And so, a desire to come back. Obviously, my life right now is just different because of the remote learning from home. So I don't teach yet. In my contract when I came back to USF, I said I wanted to focus on getting my research underway. So I don't start teaching until spring of next year, but I'm already doing guest lectures in a bunch of different classes. And I'm doing a lot with this dashboard. I still do a lot of analytics. I'm trying to learn the doctoral students and the master students who I want to work with and do some investigations. I do a lot in birth defect surveillance research. And so, it's a hodgepodge of things, which I like that. If I had to do the same thing every day, I'd go crazy. So I like that there's a lot of variation. I've got my hand in a lot of different projects simultaneously. I get to work with a lot of immensely bright and energetic students and colleagues. And so, but I think if you asked 10 faculty, you'd get some cross-cutting themes, but you'd probably find a lot of different experiences on how their day-to-day go. Like, for example, I've got a colleague of mine who so I've got a lot of my funding off of research. She only has 5% funded off of research. So she teaches like 5 classes. And so she's doing a lot of paper grading, a lot of teaching, and that's it, not a lot of research. And so what I try and do in those cases is, I try and reach out and say, hey, do you want to collaborate on something? I've already got this data set. If you can do this small portion, I know you don't have a lot of time, maybe we can start to build your research portfolio. And then if she gets a grant, she can do a little bit more research and a little bit less teaching. And in exchange, she will certainly help me, like, hey, here's all the materials I use for teaching. So, that's, again, the beauty of getting in a good fit. It's not just about when you're a master's student. It's not about when you're a doctoral student, but when you're searching for that, if you go into academia, for that first academic position, it's what's the culture here? And so that's what I loved about USF. When I came back, the dean, like one of the people I have the most immense amount of respect for, is Donna Peterson, who's the dean of our college. She's leading the coronavirus response at the College of Public Health. On a personal level, there was a dog that I had to get rid of when I changed jobs, and I couldn't have a dog there. And so she took care of my dog. So we had a personal connection. But I have such immense respect for her and the culture that she establishes at the university. And that's a big part of why I decided to return, because I kind of enjoy the people and I enjoy what they're doing and where they're heading.
Thank you so much. I'm very grateful for the in-depth detail. I like wrote all that.
Yeah, you'll never want for detail when you ask me a question. You'll probably just want for me to shut up.
And I have one more question, but I want to ask if anyone else had one, if they wanted to ask instead or not.
I do want to ask you one thing, Jason. Do you mind talking about, you know, you and I met through the Florida Birth Defects Registry. Do you mind talking to them a little bit about what that's like, doing that for the state, so they can kind of get an idea of what kind of jobs there might be if they wanted to go to a more applied?
Oh yeah, I mean, so again, you get such varied experiences. So obviously, I haven't worked for a county or a state Department of Health, but since 2005, I've worked with people in those environments. And so we talk about culture. And again, I think there's such heterogeneity in culture. Right now, though, I don't think a Department of Health is a very pleasant place to work because of the immense amounts of pressure that they're getting to produce these volumes of data on COVID-19. And no matter how good you try and do it, you're never going to do it right in some people's eyes. And so I think it is a hard place to work in. But, prior to all of this, Department of Health is a great place to work. They tend to be very, very secure jobs. They don't have the pressure. So like if I'm comparing to academia, again, for me, it's academia 100%, and I'll explain why. But if you don't like the idea, the pressure of having to get your own funding. So what I mean by that is, so I'll give you some insights that I wish I would have gotten. When I just signed my contract to become an associate professor at University of South Florida, what it basically says in my contract, and this is a pretty common portion of a contract, is for the first 3 years that I'm there, I don't have to fund any of myself through my own research. Like the college is going to pay for me. If I don't fund a lot of my own stuff through research in those first 3 years, they're just going to make me teach a lot, right? Because they're going to make me work. And so, but they're going to give me protected time to try and build that research portfolio. Now, this is not my first academic position, so I was able to come in with money. But after the 3 years is up, depending on the other details of your contract, like you need to bring a portion of your salary in through grant funding. And that's very daunting to some people. The notion that, and again, this is all going to be dependent on the contract, but I'll give you an example. A lot of the contracts that were being signed several years ago said that you were on a 50% tenure contract. So what that meant is after that 3-year grace period, if you didn't bring in the other 50% of your salary through grants, you just don't get that 50%. You may not get fired. You're going to teach, but you don't have a portion of your salary. So there, and the pressure to publish and the pressure to get grants and the pressure to get tenure and promotion, that can be a lot. I like that. I embrace the challenge. And I think, once you get used to it, it's healthy. But a lot of people don't like that. You tend to not have those pressures when you work for a county Department of Health or a state Department of Health. You still get to do amazing research. You still get to go out and do a lot of applied. If you work in environmental epi, you might go out and do some field epidemiology. If you work in birth defect surveillance, you might link and combine data sets to identify children. You might send surveillance abstractors into hospitals to read medical records and better understand the quality of care for kids with birth defects. You might design good health education and promotional materials to improve, for example, one of the things we know in birth defects that works really well is if a woman preconceptionally, before she even gets pregnant, is taking a multivitamin with folic acid. It can prevent 70% of all neural tube defects. So Hispanic populations a while back were having trouble doing that. The message was not getting into those populations. So you can be the person that designs these health education messages to make a real difference in adoption of these things that are healthy behaviors, right? For mothers and babies in my case. But it's a great place to work. Why I personally didn't like that, and I think if I would have gone into that first, I would have been fine. But there's, in my experience, a level of independence in academia. If I want to go and download, 8 software programs that I need, I can go do that like right now. If you work for the CDC or the Department of Health, at least in Florida, you got to jump through a lot of hoops to install new software. Like it's things as simple as that I like a certain level of, I know what I want to do and I want to be able to do it without having to ask a ton of people. That's what I get in academia that frustrates me about Department of Health. And then also you are a lot more in the public eye, so to speak, if you work for a Department of Health, depending on where you're at. And so there can be, you get bureaucracy anywhere you go. I feel like my experiences, you get a lot more bureaucracy working for county and state departments of health, and the political flavor of who's in charge. All of that really matters. Obviously, now with COVID-19, it's unprecedented, but it's a great opportunity. You can do a lot of really meaningful research without the pressures of academia when you work for a county or a state department of health. So Ben, I don't know if those were some of the things that.
That's kind of what it is. I mean, I think you hit on some of the differences between academia and working in that applied setting. I mean, when you're in the applied setting, you're in a cubicle or a small office, and you are in front of a computer all day. That's really all you do. I mean, that's what you and I did together, working, jointly. Whereas in academia, my day is pretty much my own. I succeed or fail on my own, but the work that I do is my own. So yeah, there's some major differences, and that can help students decide on what they want to do. So
yeah, absolutely. Anybody else? Krista, I think you had another question, or in my rambling, did I answer it already?
No, actually mine is a little more broad, and it has to touch more environmental health than like COVID-19. In environmental health over the summer, I had Professor Dowd-Arrow as my teacher, but we learned how with like climate change re-emerging and emerging diseases will become more prevalent. As an expert on this, and as like all people inheriting the future of our planet and stuff, will we see this to like continue being a trend? Like what's the situation with like climate relating to diseases and like possible future pandemics? I don't know.
Yeah, so I mean, it's a great question, and I alluded to the fact that I'm not afraid to say, like, that's not my area of expertise. It is certainly not. I'm not an infectious disease epidemiologist, and I'm not an environmental epidemiologist. I'm not a good one anyway. But what I will say is, in being at Baylor College of Medicine and being around this guy, Peter Hotez, who's the dean of the National School of Tropical Medicine, the neglected diseases around the world, things that should not be a problem at all, but that impact, places of the world mostly that are impoverished. I mean, these are the things that are major, major threats to our existence, depending on how we handle them. And they're killing just droves of people. I mean, untold volumes of people when they really shouldn't be. So I think, we have a thing in health economics that's called opportunity cost. And, a lot of people value the here and now. What do I have right now? They can't think far into the future. So give me $90 now instead of $200 in 6 months, right? Because I can do something with that. It's the same thing with climate. It's a lot harder to have people think about the future, because how long is it going to be? You have predictions that we've already done so much damage that in the next 40 or 50 years, we're screwed. But a lot of people might also think, well, I'm going to be dead at that point in time. You get a lot of, it's really hard to convince people, even though 99% of scientists say, climate change is real, it's a big concern, including neglected tropical diseases. Like, these are all the things that, keep people awake at night. Now, I'll give you another example of the unprecedented emphasis on COVID-19. We are also neglecting things like tuberculosis, which is still killing tons of people in certain areas of the globe. And we're talking COVID. How many more new cases a day? Because it's a hot topic, and it is important. But we should also have that level of fervor about things like tuberculosis, which is killing way more people than COVID-19 is. So it's a challenge. It is not the area, I can't give you the specifics on what's the next big thing or what should we do. Obviously, we need to take more ownership of the planet in which we live and make responsible decisions. I think, unfortunately, this is not a left or a right thing, but I think some of the policies that have been passed in the past several years are really detrimental to ensuring our own health and safety. The deregulation of things that keep us safe. More things that, like what happened in Flint with lead in the water. I mean, those kind of things are going to emerge if we're not, I'm not saying that government needs to control and have its hand on absolutely everything, but there needs to be some assurances that what we're putting in our bodies and what we're exposed to on a daily basis in the environment We can't be neglectful about that. We can't release harmful substances because it's not just about the climate, right? Some of these toxins that are, estrogen disruptors and what's happening with, increased likelihood of certain types of birth defects or developmental disabilities or autism, which we still don't know exactly what causes it. I have a strong feeling that, again, what's in our environment and what we're putting in our mouths, in terms of what we eat, nutrition, and where we get our food from, like, that's a big determinant of our individual and our population health.
Thank you so much. This has all been so awesome. I'm so glad all of you got the opportunity, and for me to hear you speak today, it's been awesome. Fluid water, like, amazing.
No, I appreciate that. And the people who have their camera on are not sleeping, so that's such a welcome thing. The people who have their cameras off and are on mute are probably snoring, so that's also okay. No, I'm just teasing. But no, I hope, feel free. If there's ever a topic of interest, I'm happy to talk. If there's one thing about me, I really am a kind of a type A in your face personality in a good way. I love people who are passionate about what they do, because even though every job can have its days where, I want to bang my head up against the desk and wonder why I got into this, I really do like to wake up every day and love what I do and make the best of a bad day. And so I really carry a lot of high energy. And I think, no matter what you choose to do in life, really make the best of it, because there really are days, like, especially like in my doctoral program, it's such a grind, and people are like, well, why do you have a smile on your face? And again, it's not contrived. It's like, I really try and say, okay, I'm doing this for a reason. Ultimately, this is a stepping stone to me improving people's health. And so if that's something that you're passionate about, then damn it, public health is where you should be at. So good luck to all of you. I think Ben, Krista, you certainly have my email. Please feel free to share it with the group if you ever have questions. I try and be as responsive as I can, but feel free to reach out to me. Genuinely speaking, this is not self-promotion. I could care less who actually follows me, but I'm on Twitter. I really do try and post information. If you're looking for reliable info on COVID-19, I can at least promise you that I'm very unbiased. I try and bring as accurate of information as I can. I may be wrong about things from time to time, but I will always try and be truthful and bring information that's accurate to you. So really, thank you for the opportunity. I'm so happy you formed this organization, and I hope your future speakers are way better than I am too.
Thank you so
Jason,
much.
Thank you so much for coming.
Yep.
Apparently my picture dropped out. I appreciate it. I know the students appreciate it.